Let's get oral. Let's get oral.
Hello, hello. It's Let's Get Oral. Jonathan and I are here today with Georgios Kotsakis, who originally did his dental degree in Greece and then came over here to the University of Minnesota to do your periodontal residency. And then you came out to University of Washington, where we met and did a lot of work with Richard Darveau. And then you escaped to University of San Antonio.
Let's get oral.
Yes, University of Texas, San Antonio, yeah.
UTSA.
Yeah. And now you're here. Yeah, woo! And now you're here in Jersey with me at Rutgers as assistant dean, which is incredible. I love having you close by. And I'm really excited to talk with you about your research in implants and peri-implantitis, because I think it's a huge issue that's coming up. But first, I kind of want you to walk us through how you landed in the oral cavity and what got you impassioned about implants and issues in that arena.
Yeah, absolutely. So really nice to be here with you today, Camille and Jonathan. Thanks for kind of the little retrospect of my career. It's fun to think of all the places I've been to. I come from a family of dentists, so my involvement in the oral cavity was kind of a natural progression of family history, I guess. Although I will say that as a teenager, watching my father do oral surgery, I was pretty intimidated by the whole process. And then while in dental school, to be honest with you, I had some doubts very early on if I'm really cut for this, until the moment I found out more about perio and understanding, about the depth of the linkage between physiological processes, across the entire body and the oral cavity. It was just fascinating to me to realize how this site-specific inflammatory component can actually have multi-system effects across the entire body, and how it's just manipulating, the microbiota, you can have profound host changes. So I kind of fell in love with it, and then everything kind of fell into place as I completed my residency in Perio.
Did either of your parents specialize in a specialty, or were they general dentists?
They're both general dentists, but they have advanced training in implantology. So early on, when I was working with them, I got involved with implantology very early in my career, and that really shaped what I do today, working in the field of peri-implantitis.
Excellent. I guess that's how I can really appreciate your passion for peri-implantitis and the really unique biology that happens at that interface. Cool. Well, I want to get into some of what you have to share in your research there. But first, I wanted to touch on some of the work that we've done together, because it was pretty monumental. It got some press, and I thought it was a really fun study. But you were kind of in the weeds with it for a good long while, because there was a fair amount of digging into the data and really assessing and unearthing some cool findings. I was just merely the industry side, kind of facilitating the study. So you want to tell us about that study?
Yes, I do. We had a lot of great people working on that. On the one hand, you were part of the Colgate team, and we had a couple of really cool people on that end too. I think Latanya's team and you were working on that.
Yeah, she's fantastic.
She's fantastic, absolutely. And then on our end, Rich Darveau was kind of the mastermind about the whole protocol. And then Jeff McLean is just a world-renowned expert in microbiome. So I was really looking very much forward to collaborating with both. I had just gotten to the University of Washington. And when we put it together, it was natural with my clinical background to help Shatha, who was, you remember Shatha was the PhD student running the whole show.
We'll never forget her. She's incredible.
Yeah, just such a go-getter. And Diane Dobert there, we for sure have to mention Diane. And, my task originally was just to put together the clinical component of how do we do an experimental gingivitis model in a way that is really reproducible and has some face validity. Like, we really want to make sure that we're standardizing what's happening on the one end across individuals, and it's really reflecting the reversible gingival inflammation. But then, as you said, when we got all the temporal microbiome data, it was such a tremendous volume of information that we were lost for, I would say, for months and months.
I recall.
Because it was very early on in the implementation of just oral microbiome pipelines specifically for the oral microbiota. And there was nothing to be done or said about temporal assessments, like longitudinal assessments of microbiome. So I put my statistics degree to work, and I spent over a year developing, in collaboration with Jeff, and developing the pipeline for figuring out longitudinal trajectories, like doing this clustering, but instead of doing clustering on a cross section, a specific point in time, we were able to pick up on temporal patterns of microbiome structural changes over time. And that was what really made that PNAS paper so unique, that we were able to identify this kind of third new trajectory of inflammatory response in humans.
Right. So we did a very small quadrant of experimental gingivitis. So it wasn't a full mouth design. So we could really isolate the changes that happen during gingivitis. And then you did that full assessment on both the microbiome, but also the chemokines that came out of there, and ran those trajectories so we could see that kind of interplay between the inflammatory profiles and the microbiome. And what we found was, or what you guys found, is 3 different phenotypes of gingivitis.
Yeah.
What did that look like? And why was that so profound?
Yeah, that is so true. We did look at, there was precedent. I think Trombelli studies had shown that we have a distinct response among humans, right? High responders and low responders to inflammation, which is really consistent with that hyperinflammatory phenotype that's common among multiple inflammatory diseases, not only periodontitis. But our longitudinal trajectories now allowed us to find this third component, this third trajectory that we refer to, I think, as slow responders in the paper. So these were people that were accumulating a tremendous amount of plaque. I mean, we're talking about 2-3 weeks of not brushing their teeth, protecting them with a stent from any removal of plaque, and still not really mounting an inflammatory response in the first weeks when that happens, really having a very resilient homeostatic mechanism that was protecting them. And not only that, but we found that this is the majority of humans, which is a great thing, right? About half of our population reflected the slow response that I think really mirrors what we call, from a biological perspective, the para-inflammatory phenotype. And then we also found that we had these high responders, the hyperinflammatory phenotype. And these people, the moment they start seeing this increase in microbial load and the shifts in the microbiome, they started having this exuberant response with all these neutrophil chemokines that directly signal osteoclastic maturation. So the assumption is that these cluster is the people that we have to have kind of higher vigilance, higher monitoring for prevention of periodontitis.
Right. So some are more susceptible than others, but I really latched on to the idea that high plaque formers that somehow don't get disease, because we've seen those in clinic and don't really have an explanation. But I like how you kind of stuck it with the para-inflammatory phenotype, where they will get to an inflammation status, but their healthy status is more durable than what we would kind of theorize to see. So the other thing that you guys did was you did some follow-up work to show that on the other side of the mouth that didn't have experimental gingivitis, that there were still changes that occurred in the microbiome in distal sites, in sites away from the gingivitis. Can you say a little bit about some of that work?
Yeah, this is follow-up work that Jeff really did and was recently published, again, in the follow-up paper of the study. And what was very remarkable is that the dysbiosis that we're assessing, we're measuring it clinically and biologically and from a microbiome perspective in the sites that are actually not brushed, has direct ramifications on what happens on the contralateral side. And just to put it in an analogy, right? If we have a person that has, let's say, breast cancer on their right breast, and that crosses on to the left one,
Right.
that means that we now have systemic
Right.
spread of the cancer. That's immediately stage 4.
Right.
So in a sense, if it goes to the other side of the mouth where we measured, and we have this localized response on the right side, cause an increase in the inflammatory burden on the left side, that means that we have systemic inflammation.
Right. Exactly. Gosh.
Right?
Yes.
Is that inflammation now moving down to the lymph nodes, or potentially even altering granulopoiesis, in the bone
Right.
marrow, and then eventually, ultimately, through systemic mechanisms, has repercussions on the contralateral side, which is absolutely mind-blowing given that gingivitis is such a benign, reversible inflammatory disease.
Right. Well, that begs the question, when you look at the SOPs for interventions for gingivitis and periodontal disease, we're essentially talking about only 3 sites were isolated for this study, and yet the full mouth was somehow impacted. So would you want to revise some of those intervention SOPs? Because I don't think we intervene at 3 teeth.
Right. It's kind of hard. In general, quantifying gingivitis is hard because gingivitis is such a dynamic disease. And at any point in time, you look at prevalence studies, even up to 80% of the population might have gingivitis, and it might be transient.
Right.
It might have to do with whether you brush your teeth the night before, if you're a high responder, or it might have to do with your diet. And we now know there's a brand new study coming out in the Journal of Periodontology. It's an EPUB ahead of print right now, showing that reduction in sugar intake, like dietary sugar intake, has a profound effect on gingival inflammatory markers. And there are multiple studies showing that pro-inflammatory dietary components, beyond sugar, but they're primarily carbohydrate heavy, have a profound effect on gingival inflammation. So you kind of start wondering, is it just that cleaning every 2 times a year that does it, or
Right.
should gingivitis be rather incorporated in that agenda of how do we prevent non-communicable inflammatory diseases?
Right. Absolutely. Well, and I just recently gave up sugar, and I'm kind of pissed about it right now because it's still in the early days, but I definitely feel better. I don't feel like I have a lot of sugar in my diet, but apparently enough to cause me irritation. um, but it's interesting that you talk about this kind of transient value of gingivitis. I recently went in for my cleaning, and I had a couple sites, which is unusual, but it turns out that COVID was going through our house, and that was literally my only symptom. So really interesting transient inflammatory moment. My daughter had the same issue, just one day of gingival inflammation, and then it was gone. So you're right, and I was embarrassed because I, take so much pride in my oral cavity and want my dentist to think highly of me. Anyway, moving on with the, I guess, precarious nature of diet and the prevalence of implants being placed. I know the rise in peri-implantitis has already started, and I assume that there's going to be kind of an epidemic around failing implants because there is either poor education or just anybody without necessarily having a specialty doing implants, but also the hygienists being trained appropriately to clean materials specifically with specific agents. And I know you've done a ton of work in this area, so I'm excited for you to kind of talk through different materials, the inflammatory process itself, and then how we should be teaching others or teaching ourselves how to care for these implants so that they endure. I know I've talked to you personally about whether or not we should go back to bridges, but you definitely talked me out of that because you're then creating fragile teeth or damage on either side and possibly causing more issues. So I really want to kind of get into the weeds on this issue because I think it's going to be a big one.
Yeah, the peri-implantitis pandemic, in a way, is here, right? It's not something that will come, but it really is here. And we see
Yeah.
number of clinicians just explanting implants at a very, very high rate. So it is absolutely here. Prevalence estimates are anywhere between 15 to 20% after a given amount of years, showing that about 1 out of 5 patients with implants might eventually experience peri-implantitis. And the more implants you have, the more likely it is that at least one of them will experience peri-implantitis. This is kind of scary because if you look at systematic reviews, the latest systematic review on the success of peri-implantitis treatment protocols by a Spanish group shows that regenerative peri-implantitis treatment strategies are about 40% successful. So less than half of interventions are successful. So now you have an issue with high prevalence. Okay, the number of implants going in increases vastly. We're over 1 million implants going in the US alone every year. And you have a subpar chance to treat them. So there's just a ton of implants going out and people replacing them with new. But when you look at it from a health economics perspective, and most importantly, from a patient-oriented perspective, this is not a favorable scenario. I mean, think about all the surgical procedures that one has to undergo, right? The destruction of the jawbone, really, that is part of peri-implantitis, and then the reparative processes, the time under surgery, the time under anesthesia, the extreme cost for repair. It's really a major issue that is here right now.
Yeah. So do you think it has more to do with education on the provider side or patient side or all of the above?
That's a good question. Traditionally, as periodontists, part of what you learn at school is learn how to put the blame on patients. So blame shifting is part of what we do, right? We're like, well, you didn't brush your teeth going on. You didn't floss. If you've ever tried to floss, all your teeth, you do understand how laborious a process it is. And if you do it correctly, that's good. If you don't do it correctly, nowadays we know that intradentals brushes and water jet devices do it way better than floss, but that's a whole different story. Now, when it comes to implants, we've come to realize that there's way more on the clinician side that could be done differently than on the patient side. It's a very different situation that requires a different level of accountability and awareness. I will say that the work we've done in our lab and the majority of the work that's been done by really labs that are in the forefront of peri-implantitis this past decade is all about how can we not damage the implants while we try to maintain them.
Right.
And we're finding that when you apply dental cleaning strategies, either anti-infective strategies like, let's say, chlorhexidine, or abrasive mechanical, even worse, like take curettes, for instance, right, for scaling the implants, or semi-modified instruments like titanium brushes and whatnot, this can have a detrimental effect to the implant surface, right, that renders it non-cytocompatible. So that implant surface is non-cytocompatible anymore. There's animal studies where you can place that surface after you abrade it or you acid etch it or whatnot in the mouth, and you place it in the tibia of rabbits, and there's granulation tissue surrounding it to avoid any contact with the bone, like protecting your bone from it.
Do you think that's because you've disrupted the kind of seal on it, or is it something more where the surface becomes so uneven that the tissue can't conform?
Yeah, that's a great question. We got to go in a little bit into material science now. So
Excellent.
implants are so unique because titanium implants are so unique because titanium forms this passivation layer on its outside, a very thin crust. We're talking about nanometers, like 50 angstroms thick, that is primarily composed 97% of titanium dioxide. And what this is a form of primary protective corrosion, intentional, if you may, corrosion that protects the implant from any further corrosion in the mouth or in biological fluids or in other settings. The problem is that when you break that layer, we have shown a few years ago that when you break it in an anaerobic inflammatory environment, the implant cannot repassivate, which means that now we don't have that protective crust and we have titanium metal leaking into the tissues. And the way it leaks is very interesting. It forms these microparticles. And because you know a lot, Camille, about host response, these particles are less than 10 micrometers in diameter, which means that they're readily phagocytosed.
Wow.
And now you have a metal shedding particles that are phagocytosed, and that uptake leads to extensive pro-inflammatory downstream cascades. So the implant itself now is, I don't know if you want to call it a foreign body with a classical sense of like, foreign body, giant cells and whatnot, but it acts as a danger signal, right? That is their
Of course.
perturbed homeostasis. So that's a major, major issue with what we do with the implants once they go in. And just to completely respond to your question, no, micro roughness is favorable on implants. So if the micro roughness is intentional, and we have specific surface roughness parameters that people get with sandblasted and acid etch, it's very favorable to have that rough topography for cellular colonization.
So would you walk back from titanium or just do more education around safe use of titanium?
Well, funny that you ask, because we just came out of a study, we just published it in the Journal of Periodontology, comparing zirconia implants, which is kind of the new kid on the block, with titanium implants. And we found that they both get peri-implantitis, And the treatment response to peri-implantitis is a little bit more favorable on titanium rather than zirconia. So, and there's other people who have found that zirconia, if you abrade it, it can also break down and release zirconia particles in the tissues. So there's definitely no panacea. I think the problem with both titanium and zirconia implants is that you have these extremely successful biomedical devices, absolutely successful. Integration success rates are way over 90% in extreme conditions. However, there's no reliable protocol for their maintenance and for their repair or regeneration around them. So that's the real problem. That's what we're honing in. We don't want to really change the chemistry or the science of something that's so successful across medical disciplines,
Well, I didn't even ask about ceramics, but I'm forced to now.
Right. But we would just want to hone in onto, okay, we have these surfaces, we know that they work. How do we maintain them with integrity in the adverse oral conditions with biofilms, acidic attacks, and all those kind of things?
Do tell. How do we? Once something has gone sideways, I know you've done chlorhexidine versus, I think it was hypochlorite, and found some differences there. And I know that Purnima Kumar found that there wasn't really a difference in the microbiome per peri-implant type, and she did look at ceramic as well, only until there was degradation of the tissue around the implant and the base of it was exposed. Did you see a pervasive change in the microbiota? And they were all relatively similar, but there were some differences. How would you go about intervening before you call failure?
Yeah, absolutely. So, I mean, you mentioned something very, very correct. Purnima did this kind of seminal work, and she showed that, well, look, in peri-implantitis, we have reduction in biodiversity. We have just a very unique situation that's nothing like periodontitis. And then we followed up on that, and we found that this is highly correlated, right? This reduction in biodiversity is highly correlated with titanium degradation and the presence of these titanium particles. So, what we're doing now is we're saying, okay, how can we prevent that from happening while still reducing the biofilm? And there's this new classification that we put out where we classify interventions in chemical and mechanical. And then the really scary category is the mechanical, because you can go mechanical contact and mechanical non-contact. Like think about a water jet being non-contact or an airflow device, and think about contact being, let's say, a brush or a superfloss or a metal scaler, right? And this category of mechanical contact abrasive, like the metal scaler, is really a major issue of iatrogenic damage on implants. Patients can't really harm their implants as much at home as a dentist or a hygienist can using their own device. So, use of anything that works really well for removing calculus around teeth is true devastation when used around implants, like
Oh, gosh.
ultrasonic scalers, like curettes, or universal scalers, or titanium brushes. Anything like that can abrade the titanium protective passivation layer and cause pretty much irreversible damage on that implant.
What about the chemical interventions? What does that look like?
So the chemical interventions is such an interesting category because it's also paradoxically very different to periodontitis. For instance, we looked at chlorhexidine, in a couple of different ways in vitro, and we even recently published a dog study using chlorhexidine. And what we found is that because of the surface energy and the electrochemistry of implants that are pretty much metal fixtures, we have heavy absorption of all those chemotherapeutics, especially when it comes to large organic molecules like chlorhexidine. And chlorhexidine is irreversibly absorbed on the implant surface. You can't wash it off, and has this extended cytotoxicity around any type of cell type that would want to latch onto an implant, that being fibroblast or that being an osteoblast. So if you do any sort of reparative treatment around an implant, or even worse, regenerative treatment, and you have chlorhexidine touching the implant, then in histology, we're seeing that there's a necrotic zone around that implant where no cell actually can latch onto that surface. And then, of course, breakdown of the treatment is much more likely afterwards. As a matter of fact, we know that one of the big issues with regenerative peri-implantitis treatment is that it works for a few months, where you radiographically see that radiopaque, bone graft you put in there, and then breaks down 6-9 months later because you have that consistent inflammatory component from the broken down surface.
Is that when you call failure?
I think so. I think where we're at right now, well, what we tell patients, what I personally tell patients is there's a chance we can treat this implant for you, but it's kind of a 50-50 chance. So we can either take it and then move forward, and either you have successful treatment, right? Or you have failed treatment and we explant your implant, or we can go for predictability, 100% predictability. If we just pull that implant out right off the bat, regenerate the bone, start fresh with a new implant. And what I will tell you is that never to this day have I had a patient who turned down the chance to treat the implant.
Of course.
Well, it's of course for you, but for dentists, it's usually the other way around. We have so many clinicians that make the decision for the patient. They're like, okay, especially as a specialist, right? With my referrals, I want to have as close to 100% success rate in my cases as I can. So when people refer me and I do a treatment procedure that has a 50-50 chance, then, people might stop referring to me, is the rationale that a lot of people have. But when we truly look at it from a patient-oriented perspective, people have paid so much money, they've gone through so many surgeries, lost so much time, recovery time and whatnot, to get that implant that is now part of their body, and they want to give it a good chance at saving it. So that's kind of what we do it. One attempt to treat it. If that attempt is successful, we move forward with maintenance. If that attempt is unsuccessful, then there's no second attempt. We just explant and start over.
Oh, that's rough. So, one of the issues that I see with implants being placed just upstream of all of this is that oftentimes people are having periodontal disease, losing teeth, and then opting for implants. So, what's your protocol for placing an implant in somebody who already has pathology?
What's my protocol in place? And you mean, let's say if they have a previous lesion around a tooth or a cyst or something like that?
Yeah, I mean, active perio where they're still losing bone and they're losing teeth and are going to require some intervention. What steps do you start with?
Yeah, I hear what you're saying. So there's definitely several studies showing that previous history of destructive periodontal disease, like periodontal disease that leads to tooth loss, actually place these patients in a higher risk category for actually having peri-implantitis.
Absolutely.
And maybe that's part of the hyperinflammatory host response to danger signals that is there. And there's pretty much nothing we can do for that rather than awareness and frequent recalls. But there's the other component that says if I have active inflammation going on, I have deep pockets that harbor a lot of those anaerobic, potentially pathogenic bacteria or
Right.
pathobionts, and we don't want them around the implant. So I think it's pretty established right now. I'm hoping it is established across disciplines that we get perio under control, whatever that looks like, and then we move on to implant placement. It's so important, right, to have colonization of these early peri-implant biofilms with bacteria that are overall commensal.
Yes. Right.
And where are they coming from? Yeah.
I really like the study with the water flossers showing that you get early colonizers in more abundance earlier on than just normal brushing and flossing. I thought that was a really interesting observation. So basically, you're removing all the bacteria with the water flosser, and that this allows more commensals to deposit instead of having the periopathogens kind of rich in those niches. So that gave me hope for implants and treating at home in a gentler but effective way. Is that something that you recommend for all implants?
Yeah, that's I like that you bring that up. There's like two things here. The study you mentioned that we just published using the water jet versus brush, very cool study. It's based on a gingivitis model, so it's around teeth. But what the question was there is, okay, we can see resolution of gingivitis, right? We can measure reduction in bleeding or probing or gingival inflammation. But what's the aftermath on a micro level? Like if we could really zoom in and look at the community, like what does it look like after? And that's what we did with 16S RNA-seq. And we were able to see that with this water jet cleaning, you get way more of a commensal microbiota afterwards. So it's not only that you reduce inflammation, but hopefully what the new community looks like has way more resilience to subsequent inflammation, right? It has a lot of the good key players that are part of the commensal microbiota. Now, there are other studies that have looked around implants, including some of our studies in vitro and some studies, well, one study in human by Magnuson, and they show that probably the best tool we have right now to remove biofilms from implants, both in terms of capacity, like efficacy for biofilm removal, as well as preservation of this titanium surface oxide that we talked about, is the water jet. It seems to be by far and most the best strategy we have. And the problem is that there's currently no in-office way of doing that.
Oh, interesting.
But hopefully we're working on some preclinical studies now, when we publish the dog study with a prototype to do that in office. And I'm hoping it's going to be the future,
Oh, that's fantastic.
like way of maintaining implants.
Understood. Do you think that we should convince the Delta Dentals of the world to just issue, every time you get an implant placed, some home use?
That'd be so awesome. And it would pay like immense dividends down the road, right?
I think so too.
Because a peri-implantitis, it costs a lot of money. There are at least a couple of CDT codes that come into play there.
Right.
And the cost for a case like that is over $1,000 versus, getting a home care kit that's what, $70.
Right, exactly. And then what is a failure cost?
Yeah.
Besides a lot of time and money and discomfort.
Exactly.
Well, very cool. I look forward to a huge consensus article coming out soon by you and a whole bunch of other like-minded individuals to really guide care in this area, because I think it's urgently needed. But what can we look forward to from you in the future? I know you've been working on some stuff this year. Are you ready to share any of it?
Yeah, absolutely. We have a couple of consensus papers coming out. I'm very excited about the IADR, IRG consensus, and there's a couple of papers that are already under review. So there's a lot of really cool translational researchers that are part of it and are looking at what are the models that we can use preclinically to get the right answers. And then when we translate to humans, what do we know? What are the right questions to ask? Like, what's a good outcome for peri-implantitis disease
Right.
resolution, right? And all these important methodological questions. And then we have the AAP AO consensus meeting that's happening in a couple of weeks in Chicago. And I'm definitely hoping that the realization that the implant is part of the problem in peri-implantitis, that this is the differential between periodontitis and peri-implantitis, and that's why we can't treat it, is going to come through that consensus conference. Because so far we've been thinking that peri-implantitis is a plaque-driven disease, and no plaque removal strategy works against it, because we're missing out that third part of the triangle, of causality, which is the implant biomaterial itself and its breakdown. So I'm hoping that this consensus will solidify that, so that clinicians will start realizing that, hey, we have to really preserve that implant surface as much as possible.
Yes.
In terms of our own research, we have NIH funding now on peri-implantitis, which is very cool because it allows us to really go down on a much larger scale. And I think the most important things coming out right now would be a lot of preclinical information to support a water jet device for in-office cleaning of implants, which is the best thing we've ever seen for biofilm removal. And then the second one is honing into the microbial pathogenesis of peri-implantitis and looking at certain bacterial taxa that were otherwise not considered to be pathobionts in periodontitis, now possibly being considered as accessory pathogens in peri-implantitis, a very different paradigm of inflammatory disease.
So there's different cell types too. It's not just neutrophils in this case, it's macrophages too. Is that right?
Yes, for sure. Yes, absolutely. M1 macrophages. But I would say that the inflammatory component is not that different to that of periodontitis, because you also have, max in periodontitis, and you have dendritic cells, and you have,
Yes.
T helper cells and whatnot. But I would say the way I like to draw a parallel is you have the same artillery, like you have the same weapons that the host has in peri-implantitis and in periodontitis. The problem is what causes them to come out in its case.
Fair enough.
Because that's what you need to nail down. What's the etiologic agent, and then work towards reversing that.
With the water jets, would you do anything outside of water to mitigate the microbiome or?
Yeah, I can't speak about that a lot right now, but we have some efforts focused on, hey, well, okay, we remove 97% of bacteria. I mean, it'd be very cool if we got from 97% to 99%. But what it would be way cooler is if we stick at 97%, and now we have a solution that actually helps recondition that titanium surface and make it cytocompatible again, because we don't want to forget that this competition between cells and bacteria exists, right? Even if I eliminate the bacteria, if the cells don't reattach at a higher level, gaining attachment levels, as we say clinically, right? The bacteria will still go into that pocket eventually. I mean, they will come from your tongue, they will come from the tonsils if you have them, and extracurricular, intracurricular reservoirs. So the concept is, while I remove the bacteria, what can I do to help the host cells migrate, attach, and proliferate on that implant surface? And that's kind of where we're working on right now.
Oh, that's a hush-hush then. Okay. Well, that's exciting. Hopefully it has to do with the inflammatory cascade, and that would just be a nice way to direct the microbiome as well, because that's where I love to do the interplay. I think that there's a lot of opportunity to walk back from antimicrobials and lean into other technologies to solve these complicated problems. So I'm very excited.
Right.
Yeah.
Well, cool. I'm looking forward. Jonathan, do you have anything to add?
I have more of a speculative question for you, George. So me being in the West Coast and in California, and previously being involved with the cannabis industry, there's been some emerging discussions with potential rescheduling of that as a substance. And if that were to happen, I wonder, will we potentially see such botanicals being introduced for potential therapies for addressing oral inflammation? From your previous experience of knowledge, have you ever looked into the role of the endocannabinoid system and utilizing cannabinoids for either controlling, or I don't want to say silencing, but fine-tuning inflammatory response in various models?
Yeah, well, I happen to be involved in a project like that. I mean, I travel to LA very often, but that had nothing to do with my association with that research. But we have a faculty member over here at Rutgers, Vanessa Crepa, who's doing pain research. And I was involved in one of her trials looking at CBD for dental pain, for acute dental pain, not really periodontitis per se. But I was really impressed by the potential. That study looked into CBD specifically.
Mm-hmm.
And I very interested in the analgesic effect that CBD had, which in that study was highly statistically significant as compared to opioids, which is very impactful for multiple reasons. So yeah, there's definitely interest in the potential anti-inflammatory properties of CBD and endocannabinoids and whatnot. It's not my area of research, but what I see as a tremendously untapped reservoir of future progress is host modulation, both in peri-implantitis and periodontitis. And we're really far behind because previous strategies were either ineffective based on little hacks of existing medication, like let's say sub-antimicrobial dose doxycycline, right?
Right.
Small effect or NSAIDs in the past, or they're based on antimicrobials for local host modulation, like microspheres of an antibiotic, which really doesn't make sense because what causes inflammation, right, is not the bacteria, it's the host. So if you want to shut down inflammation, you got to work on the host side. So now we're very interested in the involvement of inflammasome activation and complement C3 activation in peri-implantitis, and we're working towards that direction to be able to hopefully, through host modulation, silence host response to at least the titanium biomaterial breakdown. So then the host can only work on the bacteria. That's, I think, a very promising avenue.
So are you going to be working with Haji Shingalis shortly on that?
Yeah, I think we're trying to, we got to find the right funding mechanism for it.
Yeah.
But I think, George and John have a terrific technology that has been developed and validated. So we're looking very much forward to move that to the field of peri-implantitis.
Very exciting. I'm looking forward to that collaboration as a whole. So that's fantastic. Well, thank you so much for stepping in with us today. I love hearing all of the progress that you're making because I think that, it's a timely issue. And as we all age into potential implants, I'd like to have a consensus on how to treat effectively before we're all failing, at 60 years old. It'd be terrible.
Yeah.
What is the expectation of an implant in general? Is it like 15 years? Or forever? Can we expect a forever?
Gosh, no, I think we shouldn't expect forever. Nothing in life lasts forever, and that's the beauty of it. So, the orthopedics are way harsher than us, and part of it is the fact that insurance pays for all this stuff, right? So when they give you a hip replacement, they tell you we'll see you back in 10 years. for a little tuning.
Right.
And we don't do that. Now we know to do that.
Okay.
So if you look at longitudinal studies of implant success, it's very fair to tell people that there's an 80-85% chance, even 90% chance that in 10 years you'll be fine. But there's a chance that we might need to have a redo. Now, I think that this is a very conservative estimate. I think that well-maintained implants can safely make it to 15, 20 years easily, especially with newer implant designs. But a lot has to do with how that implant was placed.
Yeah.
There's a whole team of experts that have years in residency and training, in a hospital doing a hip implant, and it has to be perfectly in position, otherwise you don't walk, right?
Right.
If you go into the mouth and you place an implant a little bit off center, a little bit towards the buccal wall, a little bit tilted, the technician we have a lot of funny angled abutments, custom abutments, and we could probably make it work. We could probably make it so that you chew. That doesn't mean, however, that the buccal plate is going to stay on top of it, right? Or then that we are not going to have resorption because now the emergent contact angle is way over 30 degrees or whatnot. So there's so much that goes into proper training, and it's a little bit disheartening that the ADA has said that as long as people have a certain number of CE hours, which I think is not representative of what it should be. I don't think it's more than 20 CE hours, that they can go ahead and place implants, even if that was not part of what they were trained for. So I think that definitely implants are supposed to be placed by general dentists. A couple of the best implant surgeons in the world that I know are general dentists with immense experience and countless CE hours. So I'm definitely in favor of general dentists placing implants to serve the population. Shouldn't be only left for specialists, but at least having the proper education and work and mentorship to get there is so important. And we now even have that as part of classification. So one of probably the most prominent classification of peri-implant defects by Paul Rosen and colleagues has one component about the severity, how much bone you've lost, but another component of the placement of implant. Is the implant too buccal? Is the implant, too mesial? And that comes so much into play when we try to regenerate that sometimes you say, oh my God, that defect, I could treat it any day, but given where that implant is, it's not sustainable. I'd rather take it out. And that's so unfortunate for a person who spent a lot of money, are in the chair, anesthesia, recovery time, to have to tell them I got to take it out.
Yeah.
So really continuing dental education and, integrity is absolutely paramount.
Do you promote the use of 3D software for placement?
Absolutely. I think 3D software for diagnosis, looking at the CBCT scans now is becoming the center of care, and it should be. Mike Picos have been one of the best implant surgeons in the world. You probably know Mike Picos very well, and he's been advocating about use of CBCT for years, and finally it's a standard of care. And now with the opportunities to merge that with, soft tissue scans and do 3D implementation, it's so cool. So I think it's definitely a great step forward. It's not necessary to do that, for every single case, especially with experience.
Sure.
But it's absolutely cool to be able to do that for challenging cases.
Yeah, I think you would have a lot more patient engagement too, just to have all of that information that they get to look at. And I always think that engaging the patient is, a huge part of the journey to get their full investment and care, because that's what they're going to take home and really care for, hopefully.
Oh, thank you so much for saying this, because oftentimes, we kind of lose that compass a little bit, and it's always nice to tune into why are we here? And we're here to help people have amazing lives and smile confidently and chew and speak and feel in their best energy, right?
Yes,
And
yes.
how do you do that? By just, incorporate them in the discussion, making sure what will make them feel good and giving them that.
Yeah.
And oftentimes we see that back when I was teaching in residency, we had the dental students walk into the Peri residency and be like, well, okay, sit down, sir, and you have a 4 millimeter vertical defect here. And unfortunately, this tooth has 1 millimeter of attachment loss, but we can fix that for you. And patients would be lost in a sea of information. You just ask why. And hopefully we have our compass better tuned now to be able to know what is it that they care about and have empathy and genuine support for what they're there for.
I have one last question, and that is, once you have peri-implantitis, is it like periodontal disease in that it imprints permanently your inflammatory phenotype?
Wow, that's a terrific question. That's a terrific question that actually makes me think that you should write a grant about this.
Well,
You know, you know? Uh, you're not doing enough already, so you probably have to add that to your plate. And and I think we now start learning about how periodontal inflammation does that, creates that imprint, from the work of Georgios Kotsakis and Nikki Boutsopoulos and all these amazing folks. But for peri-implantitis, which is way more site-specific, by the way, right? In periodontitis, in over 95% of cases, you have what we used to call generalized chronic periodontitis, which means that the majority of your teeth are affected by disease. In peri-implantitis, we have highly, highly localized site-specific lesions. You might, crack one tooth, have an impeccable periodontium, crack one tooth, have it replaced by an implant, and then have a deep, severe, localized defect around that implant and have amazing bone protecting all the teeth, right? So it's extremely site-specific. So to that extent, I really don't know, and I don't know that anybody has looked specifically into that, and it'd be very, very impressive to answer that question.
That would be interesting. And to follow up on the gingivitis study where 3 teeth influence the other teeth, you're saying one site, but have we looked at distal sites for any pathology or microbiome shifts in peri-implantitis?
Yeah, we definitely have not. It's a very emergent. I'll tell you that the first really high quality work on the microbiome was when Purnima started looking at it, I think 2012 or whatnot, that kind of shaped the field. And then we follow up with Diane and Jeff in, I think, 2019 or something like that, where we found that, hey, titanium breakdown products in the form of particles truly affect microbiome structure. So this is all very new, right? We barely start understanding that the substrate, titanium dioxide versus cementum or dentin, makes such a huge difference that you could put an implant in a tooth, in a stent and wear them overnight for a week, and then take them out, and they have fundamentally different microbiomes in the same mouth, right?
Wow.
Based in the same mouth, just because the substrate is so different.
Not because you've caused an ulcer with each of the different. I know those things are really awful to wear.
Yeah, we do a lot of ex vivo biofilms, and if you put a hydroxyapatite disc versus a titanium disc, it is night and day. You won't even believe it came from the same inoculum. Yeah.
Wow, that's insane.
Right? It speaks of this microbial community today.
So one of the things I think about in microbiology is that some of it seems so magical, and it really has to do with our tools and how we've increased the sensitivity of our assays more recently. But it does seem like, I guess the most famous study that comes to mind is the fish to mouse and mouse to fish, where Jeffrey Gordon did the mixing of microbiomes, and the fish, after basically being inoculated with the mouse microbiome, populated its gut like a fish.
Oh, wow. I actually have not. After we're done, you should send this study my way because I haven't read it.
Yes,
I agree to it. It sounds very impressive, and
it is.
it doesn't shock me. At this point, it just doesn't shock me.
It feels magical though, like where did they come from? They must be in such low level or what, but anyway, it does seem magical on some level that is probably scientifically explained, but we maybe haven't gotten there with our tool sensitivity yet or understanding of the microbiome in its totality. But
Yeah, I'll say, we have to look at it. I love looking at things from like a more philosophical approach. I think
yes.
it's like my background that does that. But when you look at it, there's so much that comes in from genetics, right? And the microbiome you're
Yes.
born with, depending on your delivery type and all those things we know. But it's really down to the choices and the environment of how you shape things. So we now find that as in periodontitis, exposomes are so impactful. Let's think about smoking as a key exposome that has been very well researched, right? Yeah. And then in peri-implantitis now, these titanium particles alter the immune surveillance mechanisms so deeply. I mean, I don't need to even start telling you that titanium particles alone do possibly at least one step of inflammasome activation, activate ROS, oxidative stress. They increase cell death, all those kind of things that truly alter homeostatic mechanisms, right? So they're a very, very impactful exposomes that then eventually alters microbiome structure.
Well, I mean, I guess there are a lot more grant opportunities then. So I guess we should find a way to work together.
Absolutely. I'll be looking forward to that.
Excellent. Well, I'm going to call it. And Jonathan, do you have any follow-up questions?
No, you go ahead. I'm good.
I like exiting on a personal note. So are there any books that you're reading for fun right now?
Yeah, for sure. I can recommend Breaking the Habit of Being Yourself enough. I think it's on a lot of people's reading list right now. I've read it, and I was doing a little redo of that by Joe Dispenza. And then after that, a friend pushed me towards Dharma Yoga by Keith. I forget his last name, but it's kind of a deep dive into modern day application of Tao and Buddhist principles. So it's a very exciting read.
Very cool. Thank you. I love that. I'm also doing some kind of philosophical exploration, but my book is called Existential Kink. So
Maybe
it's interesting,
my
right?
reading list. Yeah.
It definitely has fun language for age-old problems. So anyway, thank you so much for coming here today. And I look forward to follow-up conversations in the future to see where we're going with what we're putting on our water jets for peri-implantitis.
Thank you both so much. Yeah, thanks for the invitation. And I had so much fun connecting with you, Camille and Jonathan.
Of course, it was a pleasure.
Likewise.
Thank you again.
Thank you.
Let's get oral.